crack on.
Hello everyone and welcome back to the Tokyo Living Podcast. I've had a bit of a hiatus for the last couple of weeks, a bit going on my end, primarily the birth of our third child. My wife and I, Lani, welcomed Archer into the world a few weeks ago, so things have been a little bit hectic as a result of that, but we're back. I've got some great guests lined up over the next few weeks, but today's guest is going to be very familiar to most of our listeners, our resident physician, back for, I think it's your fourth time or maybe even fifth, I'll have to check that. Dr. Tom Lomax, welcome back to the show.
Hi, thanks for having me and congratulations on the birth of your son.
Oh, thank you. You'll get to meet him next week, I believe. So, yeah, just make sure everyone in the clinic's teed up with their earbuds and ready to block out all the crying.
I'm sure it'll be fine.
How's everything been on your end?
Yeah, no, it's all been good. I mean, COVID numbers are down, so we're sort of starting to ease back into more regular medical care. So we're sort of seeing more routine stuff like, kids for medical checkups, doing people's routine physicals. So it's kind of nice to get back to sort of normal routine, I guess. But, we're watchful and mindful that COVID numbers may kick up again. So, yeah.
All good. Well, we'll just jump straight into the topic of discussion for today, which is going to be sort of medical management of obesity, in particular, sort of pharmacological management. You spoke about this in a presentation to your staff at Tokyo Medical and Surgical sort of Professional Development Session, which I was lucky enough to be a part of. So thank you for including us in that. I guess coming from the fitness world, I haven't really looked too closely at the pharmacological interventions. I guess there's always been a bit of a stigma amongst fitness professionals that, drugs for obesity management or even just a weight loss in general, an inferior method of management and sort of, frowned upon to a certain extent. However, every fitness professional understands that there are those patients that no matter how hard we push lifestyle, primarily diet, but also physical activity interventions, and whichever angle we sort of approach obesity management from, there are those patients that are unsuccessful. And so I think that for me, it was really useful to hear about the different options available and some of the newer options that have been shown to be successful in this space. So I guess perhaps to start off with, why are we sort of talking about this and why is obesity such a big problem?
Yeah, I mean, I think we're all aware that obesity is sort of a global epidemic now. So obesity rates in the developed world, in the US and in Europe, have tracked up sort of steadily over the past 30, 40 years. And we don't really seem to have got on top of obesity as a problem in the developed world, with the interesting exception of Japan, actually, which has one of the lowest obesity rates in the world, although there is still slightly more obesity here than there was 20, 30 years ago. But I mean, increasingly, we're seeing obesity becoming a sort of epidemic problem in developing countries as well, in emerging economies. So because we're a facility for the foreign community in Tokyo, we have a lot of patients from around Asia, from sub-Saharan Africa. And I mean, it's really, kind of alarming to see how obesity rates in those countries and in our patients from those countries are increasing. And perhaps in emerging economies, kind of awareness about obesity and the consequence of obesity isn't as good as it would be in people coming from developed countries. So it's becoming a global issue. And I think as we're sort of getting on top of smoking, which was probably the single biggest lifestyle cause of early death. That's generally on a decline globally, with a few exceptions. Maybe China, smoking still a huge public health problem. But as we get on top of smoking, I think we're now shifting to look at obesity as being sort of the number one public health, sort of lifestyle related public health problem globally. And I suspect that we'll be continuing to sort of grapple with it for the rest of my career, actually.
Yeah, and thank you for not using the line "the new smoking," so I think that's been done to death. Just out of
But it
interest,
is more
why do you?
smoking.
Yeah. Do you have any thoughts on why obesity levels in Japan are less than other countries?
I mean, they still have quite a different diet, although I mean the diet has kind of westernized in Japan. So, consumption of traditional Japanese diet, kind of rice, preserved vegetables, fish, has kind of gradually tapered down. And if you look at the diet the younger people consume, it's probably got more meat in it and more wheat-based food. Um, I mean, there is relatively high consumption of processed food in Japan, which is associated with obesity. Perhaps not as much added sugar in the food. I don't know. I mean, in the States, there's a very strong correlation between the use of high fructose corn syrup, which is added to a lot of foods in the US. That's not really so much the case in Japan. And maybe people are just more kind of aware of body shape and body image. I don't know. I'm sure there's a number of factors behind that, but that would be something that'd be interesting to follow up on another session, actually.
So I guess sort of moving on then into medical management of obesity. What has the success been with some of the previously used drugs in the space?
I mean, I guess the first thing to say is, when I sort of looked at this whole area, obesity causes a number of sort of secondary problems. So, we see a lot of obese people with, diabetes, blood pressure, high cholesterol, and so on and so on. So I think the first thing I'd say to anyone who's obese is, it's very important to get screened for those things and to address those secondary problems. And I think we've got quite good at managing the secondary health consequences of obesity, while we haven't really succeeded in actually dealing with the weight problem itself. And I mean, historically, I think we've tended to focus on dealing with people's blood pressure, dealing with people's diabetes, cholesterol, and so on, and kind of then discussing weight with them has been a bit of an afterthought. And I think, for a primary care doctor like myself, we're sort of talking to patients in, fairly short, like 15, 20-minute, perhaps maximum 30-minute slots. We often have to manage multiple problems. And, particularly people who've got weight issues will often have several medical issues that we need to address and attend to. And then actually sort of saying, well, I think, you also need to address your weight. And I think if you manage to lose weight, that will help improve a lot of these other medical issues. We'll often raise that, but it sort of falls to the back of the queue. So we're not able to really devote enough time and attention to dealing with weight. I mean, you said, what are the recent pharmacological advances? And I think before I get onto that, I mean, I do really want to sort of track back to the first thing you said, which is that, if you're in sort of fitness and exercise, you'd sort of see medical options as being rather sort of second tier. I think I'd agree with that, actually. I think, although there have been some advances now, they really are always going to sit alongside lifestyle management. And I think really lifestyle management has to be sort of the first item on the checklist. And when I say lifestyle management, I think the main thing is diet. Exercise is important, but I think people who are overweight and exercise regularly but eat a poor diet really struggle to lose weight. So I generally encourage people to look at their diet first of all, to look at dietary modifications, add in exercise, and try to maintain appropriate levels of physical activity. And I don't think it's really, I don't think it's really appropriate to be discussing drug options with anyone unless they've tried to lose weight through primarily diet, sort of augmented by exercise over a 6-month period.
Yeah, absolutely. And I did want to sort of emphasize that point that, even for a doctor, I think you've always been a very big advocate for, lifestyle interventions for not only for weight loss, but also just general health management. So we are discussing this in that sort of context that this is really a sort of a last option for a lot of people. I think it's interesting. Yeah, I was just going to say, I sort of draw parallels too with even with musculoskeletal conditions. So someone will come in, let's say they're quite overweight and they have knee osteoarthritis. We have evidence to suggest that losing that weight is going to make a big impact on their symptoms. But it's not often the things that we focus on. We'll sort of focus on, their exercise, their load management, other contributing factors, and then diet sort of or weight management gets pushed to the back of the queue in terms of priority of interventions. And I think that, even as a physiotherapist, I think we can do better in terms of, trying to combine that management into a multimodal approach. I think we're lucky, I'm lucky in the environment that I work, that we do encourage that sort of management. It is multimodal, and we have a nutritionist on staff that we can refer those people to. But even that can sometimes be a bit of a difficult discussion. If a patient comes in, you haven't yet established that that's the bond with the patient, and you're going about your diagnosis, you're going about the management options to then bring in the weight loss aspect, especially if the patient hasn't already mentioned that they believe that being overweight is related to the condition. Then it can be difficult. So it is a bit of a battle, and I think that we all need to get a bit better at trying to address those things.
Yeah, I mean, we basically need to address the issues that people bring to us, and some people don't really have, as you say, weight loss on their agenda. But we know that it will help them. So trying to sort of segue that in can sometimes be difficult. I mean, just again, very briefly before moving on to talking about drug interventions, I'll always try to do at least some brief dietary advice with anyone who's trying to lose weight. And I think I'll always suggest that people, minimize their consumption of refined sugar. Our sort of absolute requirement for refined sugar in our diet is 0. So, taking it out is perhaps the easiest thing to do and the most effective thing to do for a lot of people. But there are people who've got a very low sugar diet who still struggle to lose weight. So I'll generally discuss sugar consumption, alcohol consumption, because alcohol is quite calorific. And, essentially people who drink alcohol regularly will tend to eat more after they drink. So it makes it harder for them to sort of control their energy intake. I generally try to get people to be mindful of and limit their consumption of refined carbohydrates, white bread, white rice, although I don't really advocate sort of very low carbohydrate diets. So I sort of always try to lead with that. And some people will then go on and have a more detailed assessment of their diet with nutritionists, because there's no sort of one size fits all approach to diet. But having gone through that process, I mean, there are quite a lot of people who would, make fairly substantial efforts to lose weight through dietary changes and basically won't succeed. And then I think they feel very kind of discouraged and despondent, and will often kind of at that point just decide that their current weight is what they're left with and what they're stuck with, and trying to make efforts to lose weight are just doomed to failure. So I think it is useful to have some further steps that you can offer for people who've made efforts to lose weight through lifestyle changes and haven't succeeded. And I mean, historically, there were a few drug options that I really didn't have very much time for or very much success with. So, I mean, basically, since I think the 90s, there's been a drug called orlistat, which basically interferes with absorption of fat in your gut. I mean, some people do lose a little bit of weight on orlistat, but it's an incredibly unpleasant drug to take because, I mean, instead of getting absorbed in your small bowel, the fat then goes through into your colon, and it really messes up your bowel habits. So people get, they get a lot of gas, basically. They become very flatulent. They get a lot of cramping abdominal pain, and they tend to get this kind of oily diarrhea. So, I mean, it's not available in Japan. And the limited number of people that I, looked after in the UK who tried it all gave up on it fairly quickly because they couldn't tolerate the side effects. So I think that was a bit of a blind alley in terms of therapeutics. And then after that, and I mean, actually for quite a long time, people have been prescribed essentially stimulants, kind of modified amphetamines, because amphetamines, they act as stimulants, but they also suppress your appetite. And those have been used kind of with very limited success in a few countries, and there's kind of one mild stimulant drug that's available in Japan for weight loss, which a few people have kind of really pushed me to prescribe it. And honestly, my success rate has been like 0 on that. Maybe I've prescribed it to probably something like 10 or 15 people over the last decade. And I don't think any of them lost a meaningful amount of weight on it. So I kind of gave up on that and said, look, I really don't think stimulant drugs are going to work.
And what was the name of that drug?
I'll have to look it up because it's been such a long time since I prescribed it. Sanarex.
Start with an S? Sanarex, yes. Okay.
Sanarex. So, I mean, I think people do initially lose a little bit of weight on Sanarex if they combine it with health eating and exercise. But your body gets used to the appetite blunting effect quite quickly. So after 2 or 3 months, you basically just go back to baseline. And people who've done best on Sanarex have maybe lost like a maximum of 5 kilos over a couple of months, and then almost invariably put it back on again on the 3rd month. So again, that's another sort of blind alley as far as I'm concerned. And I think I've also got some kind of ideological issues with prescribing people stimulant medications, which are potentially habit forming for weight loss, because I kind of feel that we're just replacing one problem with another. So if you'd have asked me any time up until about July of this year, I would have said there are no good drug options for weight loss. And then actually one of my patients came to me and said, I've heard about this new injected medication that helps with weight loss and I want to try it. So I had to go and do some reading up to find out about it. And this turned out to be a family of drugs that have been used to treat diabetes for about a decade now. So these drugs are called Glucagon-Like peptide agonists, GLP-1 agonists. And I mean, they've got a number of different actions in the body, but the main one that we've used up until now is that they stimulate your pancreas to make a bit more insulin. So they don't work on type 1 diabetics, but if you have type 2 diabetes where the insulin that your body's making just isn't working well enough, these drugs will kind of augment your pancreas's natural production of insulin, which is good because there's a safety benefit there. I mean, you avoid the problems with having low blood sugars that you get with some of the other drugs used for type 2 diabetes. They're injected usually once a week, and they help control diabetes. They're quite effective drugs for type 2 diabetics, but they've also been noticed to reduce weight. So in diabetics who are on these drugs, they've generally managed to lose more weight than sort of control groups on different treatments. So over the last couple of years, one of the companies that makes one of these drugs, the drug in question is semaglutide, ran a fairly large trial using this drug on non-diabetics whose only problem was weight, but they didn't need diabetic control. And that trial was reported, it was done on just under 2,000 people, and it was reported earlier this year. And off the back of that, the FDA, the regulatory body in the US, approved this one drug, semaglutide, to be used for weight loss in non-diabetics. And if you look at the trial data, people who were given the drug lost about 15% of their body weight over a year, which is pretty impressive and, you know, substantially more than people in the control group on that trial. So, I mean, I guess that translates to, my patients who are sort of managing weight issues. I'd say that they sort of typically will start off at between 95 and 120 kilos, perhaps sometimes more than that. So that would translate into perhaps 15 kilos of weight loss over a year, over and above what you might get if you were just trying to manage weight with diet and exercise. And that's with quite a good safety profile. So, I mean, the other nice thing about this drug is it's not new. I mean, it's been in fairly wide-scale use. It's been given to tens of millions of people worldwide for about a decade. So it's very unlikely there'll be any nasty surprises in terms of sort of side effects or unexpected consequences. It seems that this drug's also known to marginally help with blood pressure control and marginally reduce risk of heart disease and stroke. So, I mean, overall, it seems to offer a number of different benefits.
Mm. You said that there's no, I mean, it's been in use for a long period of time, so the side effects are relatively well understood. What are the
Yeah.
side effects?
Right. So, I mean, the way it works, so we said that it stimulates the pancreas to make more insulin, but
Mm,
actually it has a number of different actions around the body. And probably the two most relevant ones that help people lose weight is, I mean, it has an action on the brain. It kind of, it's a signal for satiety. So if it's in your system, it will tell you that you've had a big meal and you don't need to eat anymore. Now, I mean, the natural hormone that it's mimicking is released from your stomach after you have a big meal. So, you get that
mm,
feeling after you've eaten that you don't need to eat anymore. But the hormone that signals that is cleared fairly quickly. So the injected drug version that we use stays in your body for a lot longer. So it will sort of give your brain a sort of continual low signal that you don't need to eat as much. And the way that sort of translates to how people behave, and I'm talking to people who are on these drugs, is that they'll kind of, if they're given a large portion of food, what they would normally eat, they'll eat about 2/3 of it, and then they won't want to eat any more. So it makes it much easier for people to sort of run themselves on about 500 calories less than they need, which is what we're aiming
mm,
for. So, I mean, like, let's say, a physically active man of 100 kilos might have a sort of maintenance requirement of 2,500 or 3,000 calories a day. And we want them to eat 500 calories less than that to sort of sustainably lose weight. And that just becomes much, much more doable. They don't have this sort of strong signal to eat more food. Um, so that's the effect on the brain. The other effect it has is on the stomach. So it delays gastric emptying. And so, I mean, your stomach's kind of programmed to churn food around for a certain amount of time and then pass it through to the small bowel. And that will happen more slowly. Now, that does cause problems for some people, because if people do eat a very large meal and their stomach doesn't empty in a timely manner, then they feel quite nauseous and sometimes actually vomit. So the
mm,
main side effect that people come back to me with is that they vomited because they ate too much food. And people who are using this drug need to be aware of that, and they kind of have to retrain themselves to eat a bit more slowly and to eat smaller portions. But because they don't have the same hunger signal, mostly people seem to be able to do that. So I think as
mm,
long as people are kind of mindful of that side effect and kind of work with it rather than work against it, it's manageable. But probably about 5% of people who go on to treatment with semaglutide will quit. And the main reason for quitting is basically that people vomit, and they sort of vomit
right.
unexpectedly. So yeah, I
Okay.
think everyone sort of has to be aware of that if they're going to go on treatment with it.
Sure. In the trial that you mentioned, was there any sort of long-term follow-up on that? And I guess the other question, is this something that you would expect people to take as a long-term intervention, or is it a way to, I guess, as a window of opportunity to try and get on top of the
Yeah.
weight loss and then try to work towards maintenance?
Right. So I mean, that's the unanswered question. So the trial that's been used to get approval for this drug was run over 68 weeks. So, and it's only just been reported.
Okay.
But I very much would like to know what happened to those people when they
Mm,
come off treatment. So, I mean, I guess there's a number of possible scenarios there. So, I mean, one is that, you go on this drug as a treatment for maybe a year or two, because it's going to take that long to lose a meaningful amount of weight. And at the end of that period, if you stop, then you just gradually regain the weight. So, I mean, obviously, that's not a desirable outcome. Now, does that mean that people are going to have to stay on treatment kind of lifelong? And if so, I mean, certainly that would kind of blunt my enthusiasm a bit.
mm,
And the answer is, at the moment, we don't have any data to give a sort of an informed answer to that. But I think, to anyone who's thinking about going on treatment for weight loss, I guess I'd encourage them to sort of use the time they're on treatment to kind of retrain for, basically both kind of how you eat, what times of the day you eat and what portions you eat, and also how quickly you eat. Because I think modifying those areas in the long term probably can sort of switch people to a state where they can maintain a lower weight without too much trouble. So I think it'll only work as a treatment if it sits alongside, fairly kind of extensive and in-depth advice about diet.
I guess the other factor that people would consider is the cost. Now, I'm assuming this is not something that would be covered under Japanese national health insurance.
Right. Yeah. So,
and I guess a lot of people listening would be covered privately with international insurance. Do you know if this is something that would be covered under other international insurance plans?
So at the moment, semaglutide's not approved for weight control in non-diabetics.
Right.
If you're diabetic and you're trying to lose weight, then it would be covered by Japanese insurance. So, I mean, if my advice to anyone who's diabetic who needs to lose weight would be basically, if you're on any other medications, you should be on metformin. But if you're on metformin plus other oral drugs, they should be stopped and switched out for semaglutide. And that's kind of becoming fairly standard in diabetic management. So that's one group of people who can benefit from weight loss if they're prepared to inject themselves with a medication once a week, which isn't difficult, and have it covered on insurance. Now, at some point in the future, it may be approved for weight loss under Japanese insurance, because Japanese national insurance at the moment will cover bariatric surgery. So weight loss, gastric banding or gastric bypass surgery, you can get that covered on Japanese insurance. So I suspect at some point they will look at this as a treatment for weight, and they probably will approve it. But that may be a few years off, and there's no guarantee on that. International insurance is much, much more varied. So some policies sort of specify that they will cover weight loss therapies. And I think if you're on an international insurance plan that specifies that it does cover weight control therapies, this is one that you definitely should be able to access, because it's approved for weight loss in the US now, and in some other countries as well. So definitely worth approaching insurers. And I mean, from an insurance point of view, if people successfully lose weight, the long-term health benefits should sort of pay back the initial cost of treatment. That's always been the argument for bariatric surgery, that if you get people to lose weight and then you look at their healthcare costs over like 10 or 20 years, it should more than cover the cost of treatment. But of course, we haven't proven that with these therapies yet. So there is a sort of definitely a potential for getting insurance to cover this. I guess if you're looking at self-funding it, depending on the dose that you end up on, you're looking at perhaps kind of something in the order of, 20 to 40,000 yen a month. So what's that, like 200 to 400 US dollars a month, which is not trivial, but it's not ruinously expensive. I think, people who are really serious about wanting to lose weight and are really struggling, considering self-funding this as a sort of, it's much cheaper than self-funding bariatric surgery, for example, and potentially much less harmful. So, I mean, obviously that's an individual choice for people, but it's not a sort of hundreds of thousands of dollars over the course of the treatment therapy. So perhaps it's something that people can consider.
Sure. Okay. Well, that's good to know. Anything else that you think people should know about these drugs?
I mean, I think it's still early days. So although the drugs have been used for diabetes and that they help with weight loss is reasonably well established, there are some wider issues that exactly what you mentioned about sort of maintenance of weight off therapy. Do people need to stay on these drugs long term? And I guess the worst case is, like, let's say there's a 10-year study that shows that even if people do stay on the drugs, after a while, they start to accommodate them and gain the weight back again. So there are some long-term questions that haven't been answered yet. But overall, I'm kind of quite encouraged and enthused. And I think it's a reasonable direction to go in. As I said, I've got to keep restating this, for people who've made efforts to lose weight through diet and have struggled.
Yeah, for sure. And just out of interest, so you've started treating patients with this?
Yeah. So I mean, as I said, this was first brought to me by a patient who wanted to start, And from talking to my sort of wider patient group, a number of people have kind of contacted friends or family members who are doctors in other countries, in the US, in Australia, in Israel, and in Europe, and have been sort of getting feedback that, yes, this is a good treatment, this seems to be working, it's being prescribed in other countries. So I sort of getting like multiple data points on this, and other patients I've mentioned it to have generally been quite enthusiastic. So I've got maybe, I think, about 6 people on treatment at the moment, and so far everyone that I've treated with a GLP-1 agonist has tolerated it well, has come back and said, yes, they've had some side effects, but they're manageable. And pretty well everyone seems to be losing weight, which is obviously what we're after. I mean, typically something like sort of 2 to 3 kilos a month, which I think is, really what we're after, is just to be able to do that and sustain that over a period of several months.
Yeah, that's terrific. Well, for anyone who's listening, obviously, I own a fitness facility, so we're always going to recommend lifestyle interventions, and we feel like we do a reasonable job with that. And so, if you are struggling with obesity or know someone that is, try and exhaust those options where possible. And Club 360 are here to help you with that. But if you truly have exhausted more conservative measures in terms of losing weight, I definitely see scope for this being utilised. I think that not everyone that we treat is successful in losing weight, and so knowing that there are some other options there is good. Knowing that there's efficacy and relative safety behind that is great as well. And I think that if we can help people lose weight, like you said, there's so many health implications that come secondary to that, that I think we really need to be prudent in exhausting all options that we've got. So, thank you very much for coming on and talking about this. And like I said, thank you for involving us in the presentation the other day that I found really useful, and it's definitely opened my eyes to these methods of obesity management. So thank you very much for your time, and I'll let you get back to enjoying that beautiful view of Fuji in the background there. I didn't realise you had such an amazing view from your office.
I am, but I did take that photo, so you could enjoy.
Oh, you did? Oh, wow.
Yeah.
Okay.
Yeah,
very
that's
cool.
from out in Yamanashi. That's I took that, I think, last year. So yeah.
Wow. Amazing. Very good. All right. Well, enjoy the rest of your day, and we'll speak again soon.
Thank you very much. You too.
Thanks, Tom. Bye.
Bye-bye.